Good morning. I'm Anna Wald. I'm the head of the Division of Allergy and Infectious Diseases. And this is our annual professorship named in the honor of Dr. Kirby. So before I introduce our speaker, I thought I'll say a few words about Dr. Kirby. So Dr. Kirby was the first infectious disease specialist in the Pacific Northwest, and he was recruited here, and he was one of the 6 original Department of Medicine members. He came here in 1949 and stayed here for the rest of his career. His academic work was devoted to developing assays for antimicrobial susceptibility. And he is the developer of the Kirby-Bauer plates that we still use to this date. And this has led to the adoption by the FDA of a novel then way to assess efficacy and clinical utility of antibiotics that's still used today. Dr. Kirby was a master clinician and teacher, and his family provided a generous endowment established here in his name, starting in 1986, to provide funds for us to bring an outstanding member of the infectious disease community who manifests the same qualities that Dr. Kirby did, and that's intellectual curiosity, scientific excellence and achievement, superb clinical and teaching skills, and national leadership in the field of infectious diseases. So it gives me great pleasure to welcome this year Dr. Rochelle Walensky, who already gave us a talk last night for the division and will talk here today. Dr. Walensky is professor of medicine at Harvard Medical School. She received her MD from Johns Hopkins School of Medicine and her MPH from the Harvard School of Public Health. She trained in internal medicine at Johns Hopkins and in infectious diseases at Harvard. Her research interests have focused on HIV/AIDS policy and cost-effectiveness strategies of HIV care, both in the United States and internationally. And she's recognized for motivating both U.S. and global policy toward routine HIV screening. And I think the very impressive number I saw from your biosketch was that the implementation of antiretroviral therapy has saved 3 million years of lives. So that's an incredible number. Dr. Walensky is a member of the American Society for Clinical Investigation, the American Association of Physicians, and the DHS panel on antiretroviral guidelines. And she's the past chair of the NIH Office of AIDS Research Advisory Council. She's also an advisor to WHO and UNAIDS. She has held multiple grants and authored over 250 papers. And 2 years ago, she became the Chief of Infectious Diseases at Mass General. So welcome. I'm sorry? There we go. Great. Thank you for that wonderful. Am I on? Yes. Thank you for that wonderful introduction. Hang on, is that working? Yeah. Thank you for that wonderful introduction and for the invitation to be here. I've had truly an incredible stay, and I'm looking forward to another great day of chatting with friends, old and new, which I can really say is true. I'm going to talk for the next 45 minutes or so about finding my way to the HIV policy table. Over the next few minutes, I'd like to briefly review the definition and interpretation of cost-effectiveness analyses, to review several cost-effectiveness analyses in HIV that have impacted HIV policy in the U.S. and internationally, and then to encourage all of us, and I would say all of us, hang on. Oh, okay. Does that matter? Does that work? No? Sorry.
all of us to think about costs in healthcare, in the healthcare that we deliver. And I would argue, actually, that many of us are not doing this latter thing, and that it's really important. So when we talk about cost effectiveness, people think that this is what I do. I received your credit report, and you seem to be a person worth saving. I'd like to argue that that is not what I do, but people worry about that. So cost effectiveness, we're just going to get a little primer here so that we're all on the same page about what we're going to talk about. When you say something is cost effective, you're talking about value for money. And we need to actually have two outcome measures. You need to have costs, which is usually in dollars, and we need to have effectiveness, which we report in years of life saved, or also in quality adjusted years of life saved. And in order to understand a cost effectiveness analysis, you need to understand that the numerator is about the delta resource use between two strategies, and the denominator is about the delta health benefit between two strategies. So if you have a new test and a standard of care, what's the increased cost that you're going to have divided by the increased benefit you're going to get from that new test? Now, the units of cost effectiveness are in dollars per year of life saved, and so we like low ratios. This is a game of golf, right? The lower, the better when we talk about cost effectiveness. But once you have this ratio, then you have this question, and that is, what are we willing to pay for health? Because once you have this ratio, you don't know what to do with it. In the United States, and I could spend a whole hour talking about these thresholds, in the United States, we generally believe that an intervention is considered very cost effective if it's got an incremental cost effectiveness ratio of less than $50,000 per QALY, and cost effective if it's got a ratio of less than $100,000 per QALY. Some of these are really based on old literature about what we're willing to pay for dialysis. If public insurance is willing to pay for dialysis at about $50,000 per QALY, we should be willing to pay for other things that cost $50,000 per QALY. As I mentioned, there's a whole literature about these thresholds, and in fact, Peter Newman in 2014 wrote a piece in the New England Journal that says the curious resilience of $50,000 per QALY. Why is it that all the cost of healthcare is going up, but our willingness to pay ratio seems to stay stagnant? We're not going to get into that, but it is something interesting that we should be thinking about. Now, I started doing cost effectiveness analysis in 1998. This is a graph of published studies of cost effectiveness in the medical literature. One could argue several things with this graph. Either in 1998, that was really dumb, Rochelle. Why would you ever enter a field where there were no papers? One could argue that I wrote all of those, which is not always the case. But what really happened is I rode a wave of people starting to care about costs in medicine, both domestically and also internationally. Okay, so since my research fellowship in 1999, I've been a part of a group called the Cost Effectiveness of Preventing AIDS Complications, or CEPAC. CEPAC is a group of investigators, multidisciplinary investigators, but also a group that has formed and developed a microsimulation model of HIV disease treatment that incorporates CD4 count, viral load, antiretroviral therapy, opportunistic infections. Anything new in HIV care, we code into C++. We have a full-time programmer, and we implement it into the model. We try our best to use the best data that are available. Sometimes there are no data available, but we try hard to use the best that we can using published use data sets, published cohorts, individual clinical trial data, and whatnot. And we report model outcomes in terms of projected life expectancy of two different interventions, A and B, and projected costs in terms of two different interventions, A and B. By reporting those outcomes, we then are prepared to create cost effectiveness ratios, and that's sort of the work of our group. So this is a timeline of major HIV interventions and when they became standard of care in the United States, really from 1989 to 2003. We know that pneumocystis prophylaxis was standard of care in 1989, then came MAC prophylaxis, the prevention of mother-to-child transmission with AZT in 1993, and then I characterized ART in terms of four different eras, and these were the improvements of ART over time, improvements of adherence, decreases in toxicity. And what we could do is we could use the model to generate these model-based survival curves. We could run a cohort with a mean CD4 of 84, and what would happen if they had all of these different things available to them. And we created this model-generated survival curves, and you can see the 50% survival, median survival, in the pneumocystis era was about 1.7 years. But in era 4, and this is really just art in year 2003, median survival was around 14 years. And the area underneath these curves really represents the improvements in HIV care over time. And this is my first foray into HIV policy. This was a paper that Dr. Wald referenced. And I love this slide because it's not mine. This is Tony Fauci's slide. He used it in Congress to testify in front of Congress and tell Congress that the work that we were doing in HIV care was saving lives. And so I loved this. Once this fell out of his slide deck, his standard slide deck, I was very sad. He offered me his slide. But this is really, and this is actually where I got super excited about doing policy work. This paper was published in 2006. So while the tally was 3 million, I'm sure we are well over that right now. And I was told in 2006, I was still on my K, by the way, that this would be the best paper I would ever write in my career, which was, I thought I had more time ahead of me to write more papers. At the same time, Bruce Shackman in our group was actually working on the cost side of things, and he was doing an analysis that was trying to evaluate the lifetime cost of HIV care in the United States. He was looking at a cohort with a mean CD4 of 310, and he projected an average life expectancy of about 24 years and a lifetime cost of care of these people of about $620,000 per person. Of that, ART was about 77%, and HIV inpatient care costs were about 10%. Now, this was in Medcare, and not a lot of clinicians read Medcare. It's actually a very high-impact policy journal, but not a lot of people saw this. So I got a phone call from the HIVMA somewhere around 2009 that says the government wants to know how much people with HIV cost. And I said, well, that's interesting. Why? And they said, well, you know, we've had this HIV immigration ban that has been going on since 1993. People with HIV cannot enter the United States. And President Obama really wants to reverse this ban. And we need to, if we're going to reverse this ban, they want to know how much these folks are going to care to cost for. And I said, well, go to Bruce Shackman's paper, because we know they cost about actually, the first thing I said was, they don't ask that about everybody else who comes in the United States. And then I said, but if you really want to know, go to Bruce Shackman's paper. And they did. And in July 2009, the law was changed, and it cites the economic model by Bruce Shackman to talk about the change in, this is a change in the law, the immigration, reversal of the immigration ban. Because of that, the World AIDS meeting was once again able to return to American soil, which it hadn't been since 1992, I believe. I happened to have been on the planning meeting of the World AIDS meeting, IAS 2012, and we were invited to the White House. I'm very grateful that Eric Holder is tall, because you can see him right there. We were invited to the White House, the planning committee, to really celebrate the fact that we were again allowed to have this meeting on American soil. Okay, so let's talk a little bit about HIV screening in the United States. These were the HIV screening guidelines in 1993, 1996, 2001, that basically said routine HIV screening should happen at a prevalence of greater than 1%, and then we should be doing targeted testing based on assessment. Bernie Branson at the CDC wrote these guidelines. He wrote them all 3 of those years, and he will tell you in his very humorous way that these were the most ignored guidelines that the CDC ever wrote. Nobody did this. At around this time, 2003 or so, the rapid HIV tests were being FDA approved. It was becoming very clear that the epidemic was being propagated by people who did not know that they had HIV. And there was this movement to do routine HIV screening. But it was also very clear that you couldn't do the gold standard study. You couldn't randomize half the country to do routine HIV screening and the other half the country to not and see the outcomes. So what we did is we modeled it. There was a group of us on the East Coast that was modeling routine HIV screening, a group on the West Coast that was also modeling HIV screening. We realized at about the same time that both of us had submitted our papers to the New England Journal, and we thought one might get in, but not both. And the power of this was that 2 independent modeling groups working on 2 different coasts, designing different models and populating them with the best data that they could find in the literature, but not talking to one another, came up with exactly the same conclusion, and that is routine HIV screening in the United States was cost effective. Now, I said, I'd like to say that our work helped motivate these guidelines. I believe they did. But as I said, they were really trying to, the CDC really wanted to push more routine HIV screening overall. So both of those papers were published back-to-back in 2005, and the guidelines changed in 2006, saying in all healthcare settings, screening for HIV should be performed routinely for patients between the ages of 13 and 64. And on the end of every one of my consult notes, I write, the CDC recommends routine HIV screening. Please test your patient for HIV. Let's talk about treatment. I entered this field because I was an intern in 1995 when HIV care actually became available, antiretroviral therapy. We are now in 2019. I guess I have to update this slide soon to 2020. There are numerous one pill, once a day co-formulated regimens. This is a study that was done by Ken Friedberg, my mentor, and it happened before I was really a part of the research group that demonstrated that HIV treatment was cost-effective. Now, you may or may not remember that in 1995, when antiretroviral therapy became available, it cost about $15,000 a year. And people very much said, that's a lot of money for people with HIV. That's what they said, and that's what they argued. Here is now, you can read my cost-effectiveness analysis. This is a strategy of no ART versus a strategy of 3-drug ART. You can see the delta life months, the delta costs, and then we can create the ratio. And what you know now is that that is a very cost-effective ratio, right? That's a very cost-effective intervention. You take young people who might die, you give them a $15,000 a year drug, and it's a very good value for money because they stay alive. Now, this was a DuPont 006 cohort. That was a clinical trial cohort. And people said to us, well, what about a cohort like that at Johns Hopkins, which may not, we use the term in our research group, floss their teeth as well as clinical trial participants. But in fact, and they may have lower CD4s, they may be a little less adherent. But in fact, if you even take that cohort, their survival benefits are probably not quite as large, and their cost-effectiveness ratio is a little bit higher, but still a very cost-effective intervention in the United States. So here's the issue, and that is in 2001 when this was published, 1999 when maybe we were looking at the data, ART costs $15,000 per year. And so here is where we are for first-line ART costs in 2018. So this is a graph, and this was actually really interesting to do. Since 2012, the guidelines have published the annual wholesale price of every antiretroviral agent. I might have joined the guidelines in 2012 and suggested that that might be a good idea. So these are the first-line regimens, and each regimen is shown in a different color. When it drops out of being first-line, we went from solid to hatch, just to sort of see if by dropping out of first-line, the cost went down. And in fact, they really don't. What's incredible here is now all first-line regimens that in 2018 lie over here and range really between $40,000 and $50,000 per year. Kind of amazing. If you take those average costs of the first-line regimens since 2012, ART costs have increased since 2012 34%. It's astronomical. And the rate is 3.5 times the consumer price index. That's what's happening in antiretroviral care costs. It's crazy. Okay, so then one might say, well, what about generics? Like, that would be the next thing that you'd want to know. So let's talk about efavirenz. And I like this story. This is a really hot mess of a slide. But this is when antiretroviral regimens became standard of first-line ART. So green means each row is a different antiretroviral drug, and green means it was the standard of care. So you don't really need to know this except to say there's green all over the place, so it's changing very quickly. Except this line right here, which I highlighted in pink. This is the only regimen that has kind of stood the test of time, or at least did stand the test of time, and this is a regimen of efavirenz. So in January 2012, generic versions of lamivudine were available, and generic versions of efavirenz were thought to be coming soon, and efavirenz was first line, and there was all this excitement that maybe we would, for the first time ever, have a potent, largely generic first-line regimen of generic efavirenz, generic lamivudine, 3-TC, and branded tenofovir. So we did the analysis and we said, well, if you have no ART and you add branded ART, you increase your life expectancy, you increase your costs, and you have a very cost-effective ratio. Turns out now it's a little bit less cost-effective than the ratio I showed you before because ART's more expensive, right? If you add in a generic regimen that might not work exactly like branded ART, and the only reason we said that it wouldn't is because the pills couldn't be co-formulated, so you might have a little bit more of a pill burden. That was the only difference. It might cost quite a bit less. Now, all of a sudden, your branded or your generic ART is $21,000 per quality, very cost-effective, but your branded ART is less cost-effective. I've never received more hate mail for a paper than I got for this paper. We also looked at the potential savings you could have if you took everybody who was on efavirenz and just switched them to generic, and you took everybody who had new HIV diagnoses and you put them on a generic regimen, and we said in just a year you could save almost $1 billion, which was really kind of incredible. So this paper was published in 2013, and like right on its heels was this analysis that was done by the ACTG that found that the incidence of suicidality for 1,000 person years was higher if you were on efavirenz than if you were not on efavirenz. The rates were incredibly low, 47 events versus 15 events. There were 8 suicides in the efavirenz group. This is after about 10 years of data, and 1 in the efavirenz-free group, and the conclusion of this study was that the initial treatment of efavirenz was associated with a 2-fold increased hazard of suicidality, and all of a sudden, within the year, efavirenz was demoted. So finally, we might have had a regimen that could have saved some money, and efavirenz gets demoted. And if you ever want to have a really good time, spend some time in the product sales of some of the pharmaceutical industry information. And essentially, what you can see is product sales went down 40% in the next quarter. Not surprisingly, people did not want to use it. So let's talk about PrEP. I have some giants in these spaces when we think about pre-exposure prophylaxis. One of the fun things about modeling is we get to think about some of these questions before we have data. So our objective in 2009, and I highlighted this was a study done by David Paul-Thiel in our group, in 2009 was to say, let's weigh the considerations of PrEP: cost, viral resistance, toxicity, and behavioral disinhibition, and to provide some practical guidance regarding the clinical and economic circumstances under which PrEP might serve as an appropriate use of prevention resources. So even in the absence of the data that many in this room would be providing to us, could we actually set some benchmarks? And I like this 2009. This is a nice summary slide of a lot of the PrEP efficacy trials, many done by folks here in this room, that demonstrated the PrEP efficacy, but all of them were published after 2009. So we didn't have any data. We were in kind of wide open space. And this was the result of that analysis. Essentially, we didn't know what the efficacy would be, so we ranged it from 0 to 100%. We didn't know what the annual incidence would be, so we ranged it in the United States from 0 to 3%. And we basically created what we now call a heat map that said, well, if you have a 70% efficacy and you're operating somewhere between 1 and 3%, you're going to be in a pretty cost-effective space, right? But if you can get to 90% efficacy and you have a really high incidence, you could potentially save money. We don't spend a lot of time thinking about how we can save money, but this was really an interesting space to think, well, we could actually give people prevention drug, and because of all the infections that we would avert and the downstream costs of the lifetime costs that they would have, we might actually save money by using PrEP. Now, this was in 2009, and at the time, PrEP costs we assumed would be $4,700. So of course, annually. So of course, lots of studies that were happening in PrEP, lots of motivation, and in 2014, so in 2012, Truvada was approved as the only drug for PrEP use, and in 2014, we had the CDC guidance of how we should be using PrEP in the United States. I might have argued that they were a little bit too liberal and that they might not have fit in our cost-effective plane. But these were the CDC guidance. And let's look at what happened with Truvada costs. So since it was FDA approved in 2004, this drug hasn't changed at all. Its indications have changed, but the drug hasn't changed. And it went from $7,800 to over $20,000. In fact, today it is $24,000. So if you look at the cost of Truvada this is not resource-poor settings, this is resource-rich settings, right? Ours is, Truvada costs here in the United States $24,000 per year, and that is over 2 orders of magnitude more than any other resource-rich setting that we looked at, which is kind of incredible. We looked at Australia because what we wanted to do is see how many people were using PrEP as a function of price. Now, granted, there are a lot of things that go into how many people are using PrEP, but price is probably one of them. And we mapped this, that was published earlier this summer, that essentially looked at if you were living in the United States where PrEP cost $20,000 a year, your coverage was about 20%. If you were living in Australia where PrEP costs about $94 a year, your coverage is over 60%. If coverage is at all related to how many transmissions are averted, it's probably the case that the more coverage you have, the more transmissions are averted, and that cost probably has a function in that role. I was honored to be asked to speak at the first congressional hearing on an antiretroviral since AZT. And that happened with the good Congressman Cummings, who had just passed away. But he was there, actually had just been released from the hospital that morning, to talk about the cost of PrEP drugs as part of the fact that we are trying to end the epidemic here in the United States. Okay, so in that context, let's talk about ending the epidemic. So this is the so-called HIV treatment cascade that we all know in HIV care. It's a cascade of people who are HIV diagnosed, HIV infected, diagnosed, linked to care, retained in care, and then ultimately have an undetectable viral load. And we know that those folks who have an undetectable viral load likely can't transmit virus to anyone else. In fact, can't transmit virus to anyone else. But that everybody else here is essentially has the potential to be transmitting to other people. This great slide, I think, from the Kaiser Family Foundation actually also demonstrates that while we have the most expensive antiretrovirals, we are actually doing the poorest in terms of this outcome of trying to get people virologically suppressed. And these two are not resource-limited settings. These are all settings that are resource-rich. And here we are sitting on the very right of this graph. So in 2015, the Obama administration updated what was really the first national HIV/AIDS strategy with the goal of reducing new infections, increasing access to care, improving health outcomes, reducing HIV disparities, and really coordinating an epidemic response. And their key indicators were to try and get 90% of people in care and retained, and then 80% of those suppressed. And we thought, well, wouldn't it be interesting if we could prove that this was a cost-effective intervention? So we set out to do that. We determined the clinical and economic impact of reaching the target U.S. national HIV/AIDS strategy goals, both in the general population, but also specifically in perhaps a harder-to-reach Black gay man population, with the goal of 72% suppression, and you get there by 90% diagnosed and 90% virologically suppressed. And we modeled that you'd have to pour in a lot of resources towards testing, towards retention, towards adherence in order to do that. We demonstrated that it was actually a cost-effective intervention in both populations, and in 2017, mind you, a different administration, they updated the national HIV/AIDS strategy, and they cited our work, which I was really pleased about, less so that they cited our work, but more that this administration might care about this, and noted that in a study published in JID, we reported 250,000 new HIV infections and 200,000 deaths in the United States could be averted over the next 20 years if we actually reached that goal. So I was a little optimistic. Later that year, the Trump administration actually fired all of the members of the HIV/AIDS Advisory Council, and this was the ominous, we really are not going to make progress here, and we're not going to make progress for a long while. And that happened December 29th. I had all sorts of, I had to pick my favorite headline for this one, which was really sad. Until February 2019, when we didn't really see it coming, but the State of the Union address from the Trump administration basically said, we're actually going to end this epidemic, which was great. And all of a sudden, there was this real new momentum, credit to Tony Fauci for his leadership here. And they actually put new money in. And they said $250 million in additional funds in 2019, focusing on transmission hotspots with the aim of reducing new HIV infections by 75% over 5 years and 90% in 10 years. Now, I read this, I scratched my head, I said, well, we've already done that analysis, I wonder if we could do that, and I wonder how much we said it would cost. So the State of the Union address said they wanted to reduce transmissions over 5 and 10 years, and they were going to give us $250 million. And if you mapped our assumptions and our results over this, we basically said, that's the JID paper, we basically said you could reduce transmissions by 40% over 20 years, and it would cost you $120 billion. So the administration was off by about 3 orders of magnitude, and I think probably off by how aggressive we could be in terms of how many transmissions we could avert. Importantly, the JID paper that we did not use PrEP. We used only ART as preventing transmission, so I think we could probably get transmission reduction down quite a bit more. It's also the case that PrEP is much less cost-effective than antiretroviral therapy, so the more we push this down by using PrEP, the more the price tag goes up. This was picked up by the New York Times. Strategies bound to end the AIDS epidemic, but expenses mostly for drug costs of up to $50,000 per year is an inevitable obstacle. So this is the map of the plan to end the HIV epidemic in the United States. These are the 48 hotspots in 7 states that have really been targeted. You all are up here, obviously, and I am the other northern blue dot. So we share that in common. And again, hats off to the Kaiser Family Foundation, which actually noted this really important thing, and that is that those sites in orange, the regions in orange, have not expanded Medicaid. And so we're kind of putting our hands behind our back trying to end an epidemic where we don't have insurance to do so. So that's going to be a big problem as we try and figure out how this is going to happen. All right, I want to have one more domestic story to tell you, and that's about the impact of smoking. I happen to work now with this terrific junior faculty member who's a pulmonologist, and he knows a lot of things about smoking that I don't know. But what he did sort of note to me is that our primary care guidelines on smoking are not awesome in terms of HIV. They were not updated since 2013. I understand that they are currently being updated, and that's where they mention smoking cessation. See it right there on page 27? Turns out that while only 15% of the U.S. general population smoke cigarettes, 40% of people in the United States with HIV smoke cigarettes, and those are rates that are similar to the U.S. population in 1965. It's incredible, right? And so while smoking, and he found in this study, smoking as compared to HIV itself has double the detrimental impact of HIV in our patients who are taking antiretroviral therapy. So once you have your patients suppressed, we have more work to do. He also demonstrated in this analysis where the different lines represent heavy, moderate, and light smokers, that if you are a smoker compared to if you were a former smoker, you had much more lung cancer. So 25% of ART-adherent smokers will die of lung cancer, not of HIV. And ART-adherent male smokers are 10-fold more likely to die of lung cancer than they are of their HIV. So I think we have a lot of prevention services that we have to offer our patients, beyond which antiretroviral therapy. We have more work to do. I want to turn briefly to talk about a few studies that we've done internationally, because while we are very worried about the epidemic here in the United States, we also know that the resource-limited settings have really been struck with this epidemic well more than we have. So we sought in 2004 to take our model international. And it turns out that HIV was the easy part. We had to populate it now with new data from regions where TB is more, where OIs are different, there's more TB. And then we really needed to populate it with different cost data, right? Where different regions of the world have different cost structures. Obviously, antiretroviral therapy costs are different. And then what was really interesting in this process was we had to think about the fact that the natural history would progress, and providers might not know the information. So here we will get a CD4 count, the model gets a CD4 count, and the provider knows a CD4 count. But in fact, in resource-limited settings, you might not know what the viral load is. You might not know that somebody failed therapy. You might not know that they actually have an OI when they present to care. And those were some of the challenges when we built this internationally. We now have colleagues in 14 different countries. We are analyses are generally based in South Africa, Cote d'Ivoire, and India, but we've done analyses now in Mozambique and Malawi and Brazil and Botswana. It's really great fun. The model gives us the same outcomes, mean projected life expectancy, mean per person costs. And we generally use the GDP, the country-specific GDP, as a benchmark for cost effectiveness in these studies. Again, that could be a whole topic about whether that's appropriate or not, but we need some benchmark to look towards. So in 2014, the UNAIDS had this 90-90-90 strategy. It was actually just before the Obama administration national HIV strategy. It's the one the Obama administration relied on. And the plan was 90% of people diagnosed, 90% on treatment, 90% virologically suppressed. And the current estimates at the time were that the global price tag for scale-up of 90-90-90 would be $36 billion. I happened to be at a UNAIDS meeting, advisory council, and they said, well, we wonder if this is a good value for money. And oh, by the way, the UNAIDS is going to be at the General Assembly, in a year. And so money donor agencies and in-country policymakers really wanted to get a complete sense of if we got to 90-90-90, would that be good value for money? So, of course, I went back and, did literally the back of the envelope calculation on the plane home from Geneva, tried to figure out whether this was something we could model. And we used a mathematical simulation to inform partner countries by estimating the return on investment of reaching 90-90-90. What would you gain? We did this in South Africa, and we projected in just the 10 years between 2016 and 2026, in South Africa alone, that if we reached 90-90-90, 2 million transmissions would be averted, 2.5 million deaths would be averted, 13 million years of life would be saved, 1.7 million children would not lose their mothers from HIV/AIDS, and the incremental cost would be $16 billion, but it would be a very cost-effective investment over 10 years at $1,260 per year of life saved, which is quite cost-effective in South Africa, which actually is really a middle-income country with a GDP of around $6,000, $7,000. This was presented at the General Assembly. This was quite fun to go to. And really, I think this was a really energizing meeting to present these data. That was 2016. We all know what then happened. We got this America's First Budgetary Blueprint, which said in the new administration, so that was June, so in the new administration, that the Budgetary Blueprint was going to provide sufficient resources to maintain current commitments and all current patient levels on HIV/AIDS treatment under PEPFAR and maintain current malaria funding, but there would be a 18% cut to PEPFAR, a 17% cut to the Global Fund, and a $1 billion reduction to state USAID and CDC Global Health. So I'd never quite done this analysis, but it became very clear that while it was really fun to think about what would happen if we scaled up, rolled up more services in these settings, our model could be used to see what would happen if we actually rolled it back. And that's really what, and it was really painful research discussions about how you would roll back care in these settings. What would be acceptable? We ultimately said we would never set a strategy that said if you presented dying, you wouldn't get care. And that was actually the lowest bar we set, but that is where we were. It was really, these were terrible discussions. I was invited to a congressional briefing in March just after this rolled out, before we had actually done the analysis. But this really motivated in the analysis because the staffers really needed to understand and know what was going to happen if this care rolled back. We did this analysis both in Cote d'Ivoire and South Africa to demonstrate what would happen in really a middle-income country versus a very low-income country. In South Africa, we found, and the results were pretty similar in Cote d'Ivoire, that HIV transmissions would go up by at least 20%. Deaths would increase over the next decade by at least 40%. And really, if you just assumed that if you were dying, we would take care of you, there was a maximum of 30% of the budget could be saved because, in fact, people came in needing more care when they were sicker. we concluded this, and I like to read this because this was, we struggled a lot with how to conclude this study. For every year of life lost in South Africa and Cote d'Ivoire, HIV programs would save somewhere between $600 and $900. And we wrote, we leave it to readers to draw their own conclusions about whether imposing such trade-offs on vulnerable populations accurately reflects how donor countries vary life in recipient nations. I did mention when I was at the congressional briefing that I asked these like 20-some-odd-year-old staffers to take out their iPhones and say you could save a year of life for the phone that is in your pocket. And I think that kind of hit home. So the final study that I just want to mention is one that was really near and dear to, I think, a lot of our hearts over the last couple of years. There was this great breakthrough in 2017 about the pricing of antiretrovirals in resource-limited settings. So we are using dolutegravir here. Maybe many are using bictegravir, but we are using dolutegravir here in the United States, and that is really considered first-line antiretroviral therapy and integrase inhibitor therapy. And the Clinton Foundation worked with UNAIDS, worked with PEPFAR, and basically said that we were going to be able to get TLD, tenofovir, lamivudine, and dolutegravir, essentially a first-line regimen in the United States, for $75 a year in resource-limited settings. Kind of incredible. So this happened in September of 2017, and PEPFAR all of a sudden started stockpiling dolutegravir into PEPFAR countries, and it was really exciting that we were going to roll out a U.S. first-line regimen in these settings for that price. Mind you, this is $45,000 a year here, right? Okay, and then this happened, and I think we all remember where we were around the time of May 2018 when Rebecca Zash at the BI had a study that was asked for by the report Scientific Advisory Board that demonstrated that women in Botswana in the SIMPAMO study, this was not the outcome that SIMPAMO was setting to look at, found that if you were on dolutegravir when you conceived, that there was a statistically significant increase in neural tube defects. And it wasn't clear why, and it really wasn't clear what to do about this. But essentially what happened is folks basically said, all right, no more dolutegravir for women. How can we say that? No more dolutegravir for women, we're just going to give it to the men? Okay, maybe no more dolutegravir. Or what should we do, right? And so what became very clear is, first of all, neural tube defects are terrible. Everybody wants to avoid them. They are emotionally terrible. And so there was this real gut response that we really want to avoid neural tube defects. But we thought, well, this is really something. We have an adult model. I haven't talked to you about a pediatric model, but we also have a pediatric model where we look at pediatric outcomes. And we said we could actually model this. And we said we wanted to project the clinical outcomes for women and children associated with a dolutegravir-based ART versus an efavirenz-based ART for women of childbearing potential over a 5-year period in South Africa. And we left the cost out of it because we basically said we need to figure out what the clinical outcomes are here. It's not about whether this is cost effective. We spent a lot of time over the ensuing months to try and get to the root of the question. This was led by Caitlin Dugdale in our group. And essentially what she found is for every neurotube defect averted, you would have 5 more deaths, you would have 22 sexual transmissions, you would have 4 mother-to-child transmissions, and about 0.3 more child deaths. And really, was that the trade-off we wanted to be making? It's certainly the neural tube defect we want to avoid, but once you quantify it and say all of these other things might happen if you avoid that singular neural tube defect. And so I think over time, I think PEPFAR has been interested in these data. Also, this is Caitlin presenting these data first at AIDS 2018 and then updated analysis in AIDS 2019. She's been on a sort of whirlwind tour at the WHO and UNAIDS to try and inform these discussions. And then the SIMPAMO study was then ultimately updated and published in the New England Journal just this year. And the point estimate has actually gone down, which I think we're all relieved to see, from 0.94 to 0.3. But we had done sensitivity analyses on, we actually had done sensitivity analysis on the whole range of point estimates to sort of say what would happen if we really remove dolutegravir, what if the point estimates go up, what if they go down, and what would those trade-offs look like. So with that, I will conclude and just sort of say again, cost-effectiveness analyses and mathematical models do provide a flexible methodology to address policy changes in many areas, both in the United States and in resource-limited settings. I have had this incredible privilege to work collaboratively with colleagues across Boston, the United States, and to train the next generation of people who I hope will embrace more mathematical simulation models. And to ask you to sort of join me in this effort to try and really think about costs as we are prescribing things for our patients. I would say we are not paying attention. I know our folks on the Northeast are not paying attention because most people don't know to the order of magnitude what anything costs. And I would say it's time that we do. With that, I will say I've had an incredible few days here in Seattle. I've been generously treated and incredible hospitality, so thank you all very much. Thank you.
Thank you, Dr. Walensky. Questions for Dr. Walensky?
Fascinating talk. Could you say something about Medicare copays?
Not a lot. So, I'm actually working with a group at the Kaiser Family Foundation to talk about how we finance HIV care in the United States. The biggest problem, I think, with providers is with providers trying to use cost-effective care is that we actually don't know what our patients pay, right? And in fact, we tried to map what do our patients pay when we prescribe this versus that, because there's Medicare copays, there's drug assistance programs by pharma, and in fact, they've created incentives that you would actually pay less if you prescribe the most expensive drug. So that is really a problem, actually, because that person will pay less, but somebody else somewhere else is paying more. And what's the problem with Medicare co-pays and is that they differ by state, they differ by insurance, they differ for every, so it's very hard to understand that mess, and it's, I think, intentionally opaque. So it's not a lot I can say about it because it's really complicated. What I will say, though, is people worry about generics because if every time you pick up a pill, and they can't be co-formulated, if every time you pick up a pill, it's a different copay, by trying to save the system money and using generics, your patient may have to pay more because they have to pay 2 copays or 3 copays. And that's a big problem, too.
Rochelle, it's Wes Van Voorhis over here. Wonderful talk. And I'm just curious, with your experience in lobbying and so on, what should we do about the drug costs? What should we lobby for? You told us it's a huge problem, but going up 37% a year or whatever, how do we get this under control?
I think so there are 2 answers to that question. One, I'll just be honest, 340B is a huge problem. And the reason 340B is a huge problem, for those of you who don't know 340B, it's a program that we use often in cancer and often in HIV. We actually don't have the program in HIV in our hospital. But essentially what happens is the hospital pays a low amount for the drug and gets in kickback the delta between the true price and the what they pay. When you do that, the hospital benefits from having very high drug prices. And in fact, it's not just that the hospital benefits, but then that delta goes back to feed our patients and to do really great things for them, right? And so we're caught in this catch-22 that if we drop if we drop drug prices, we have less resources for our HIV patients. So somehow that vicious cycle has to be broken. And I know folks at NASTAT are working on that. They are really sort of saying we do need to drop the drug prices. This is what it's going to do to our 340B programs. When you drop the drug prices, we need to be made whole so that those resources are available for our patients. And I think that really is key because there is this incredible perverse incentive in 340B to try and have high drug prices. That's a problem. The other thing I think is that if we pay attention to the cost, so every time I round now, I say, well, why don't we use Truvada instead of Descovy? And my fellows are like, we can't do that. Everybody's using Descovy. Like, that's the new drug. That's the hot thing. It turns out pharma's got a lot of money to market this, and people drink the Kool-Aid because that's what they see, unless they're informed. And so I really think it's our responsibility to be informed about what is actually the incremental benefit of Descovy versus Truvada, and does this patient need that incremental benefit, and is it really worth the increased cost of those two drugs? And I would argue in many of the cases, it's probably not. In fact, I would argue if you have a patient on efavirenz and they're doing well, keep them on efavirenz, right? Some people might say, well, maybe you should take them off efavirenz and see if they're actually doing a little bit better. I might agree with that. But there are a lot of people who are on efavirenz for a very long time and were doing just fine. And so, you know, it might very well be that for those people, we should be using efavirenz. So I think paying attention is really part of the issue. Docs don't know what drugs cost. Hi, Ken.
Rochelle, that was fantastic, and thank you for taking on some of these challenges. With Truvada becoming generic in the next year, could you sort of forecast, is there a way we can sort of insulate ourselves or somehow prepare for the likely commercial messages that Descovy is better than Truvada, and get to the kind of that wonderful slide you had on coverage, if cost and coverage by using generic Truvada preferentially? I mean, just what are your thoughts and recommendations about how to make better advantage of PrEP as Truvada becomes generic?
Yeah, thank you for that. So I've spent a lot of time over the last 2 or 3 months thinking about this. What's happened now is pharma has put on Facebook, has put in lots of different places, update your PrEP. To the people who are on PrEP, and people are coming in and saying, I guess I should update my PrEP. Lots of docs will tell me, my patient wanted it, he was fine, I didn't have anything to do for him that day, so I thought it would be a good idea to update his PrEP. And we have a lot of people in Boston who are updating PrEP. What I would say is, it's been fascinating to watch the ads. So Truvada is like the gold standard. It has been used since 2004. It has been the backbone of therapy since 2004. And all of a sudden, when TAS became available, it was marketed like poison. Now, I just want to remind you, it was marketed as so toxic, and there were so many improvements in the toxicity profile if you just put your people on TAS. What I remind people, and I actually said in the hearing, was it can't be that bad because we give it to people who don't have disease, right? We give it to people who are HIV negative. How bad could this drug really be, right? But the marketing is really a problem. Now next year, it is going to be the case that Truvada should go off patent. I think it will probably be a decrease in cost of somewhere between 50 and 75%. And we've done some modeling analyses that will look at how much should we be willing to pay for the benefit of Descovy versus the generic cost of Truvada, and it's not a lot. So I think what Gilead is banking on is that they can get enough people on Descovy that people will not want to revert to a generic drug. And so there's this massive campaign to switch people before it goes generic, because then people will say, well, that toxic drug that's cheaper, I don't want that. So we have to pay attention to that.
Rochelle, thank you for a terrific presentation. I was really glad that when you talked about the end of AIDS, or ending the AIDS epidemic here, you pointed out the disparity between what had been appropriated and the cost needs. But beyond that, you know, I think most people at UNAIDS feel like it didn't work out so well when they started talking about the end of AIDS. In fact, it was people, including Peter, have said it was catastrophic. I'd love to hear your thoughts about this strategy of talking about ending AIDS in the United States.
Yeah, I mean, I wonder if the phrase is really related to the person who was delivering it. There is some bombastic talk that comes from, the person who said, we're going to end HIV. And so, while I agree with you, I'm not sure it went great globally when we said we're going to end AIDS. I do think it gained momentum, and especially there was a good year and a half where every policy that came out of this administration clearly worked against our patients, I would say. And so I think on balance, it's better to have something, even if we call it the end of HIV, ending the HIV epidemic, than nothing or than where we were. But I agree with you. I think it's ambitious. What I have asked at policy tables that I've been fortunate enough to be at is what happens in a year. Or 5, or a year. If this administration turns over, what happens to end the HIV epidemic? Because there's a lot of momentum right now where people are really talking about how to do it and where to put resources and how to think about those resources. I'm under the impression that people think that this will traverse administrations even if they change. So I'm encouraged by that, but I would agree with you. I'm not sure it was the wisest term to use, but I'm pretty encouraged by the momentum that it's given. I've talked to folks in Atlanta and said the budget to end the HIV epidemic in the United States isn't enough to end it in Atlanta. But it is also the case that it's the first time the National HIV/AIDS strategy under the Obama administration was lovely, but it was completely unfunded. So having new resources, I think, is a positive thing.
Thank you for that talk. Just a quick comment, as you said, about the marketing, at the VA, with our own different discounts and negotiation with pharmaceutical companies, Descovy doesn't cost any more than Truvada right now, and so there's switch going on. But as you mentioned, when that changes moving forward, the switch back is unlikely to happen. I'm curious, moreover, just feeding into this question of regulation of the pharmaceutical industry, you mentioned approaches we can all think about, individual decision-making, practicing high-value care, complex policy proposals, payment models. The regulation of the industry side, have you crossed over into that sphere at all in the advocacy realm? Obviously,
let's just say I'm not getting a job at Gilead. So yeah, I've done some. I really think that we need to have loud voices at these policy tables. So I haven't done a lot, but I will. Your comment about Descovy, I just want to say that's not just with the VA. That was a calculated decision by Gilead to keep them exactly the same. Any rational decision maker would say exactly the same price, less toxicity, let's switch over. And the plan was when this goes generic next year, nobody's going to go back. So that's everywhere, actually. And in fact, it's hard to do a cost effectiveness analysis because you'd always go to the exact same price, better drug.
Folks with further questions, please bring them up to the front, and let's give Dr. Walensky one last huge round of applause.